Welcome to The Explainer. Today, we're unpacking a massive paradigm-shifting nomenclature change. I'm putting on my reproductive endocrinologist hat here to guide us through what was formerly known as PCOS and what we're now calling PMOS. We're going to dive deep into the pathophysiology, the clinical signs, and the modern management strategies that are totally reshaping how we care for these patients.
So, here's our clinical roadmap for today. We'll touch on the shift to the PMOS name, the endocrine and metabolic pathophysiology, clinical signs and diagnosis, the limits of conventional therapies, the use of GLP-1 agonists for reproductive rescue, and finally, a solid preconception protocol and key takeaways. Let's get into it.
Section 1. The shift to PMOS, beyond ovarian cysts. We absolutely have to start with this critical evolution of the disease's name, stepping away from what is, frankly, a century-old misnomer. There's a brilliant quote from Dr. Rekha Kumar that perfectly captures why leading experts pushed so hard for this change. She points out that focusing solely on the word cysts completely obscures the profound metabolic risks going on underneath. You literally don't even need to have cysts to have this condition. For decades, that old name caused delayed diagnoses and unnecessary stigma, kind of boxing the disease in as purely a gynecological issue rather than the systemic metabolic beast that it really is. So the acronym PMOS officially steps in to replace PCOS. It stands for Polyendocrine Metabolic Ovarian Syndrome. Polyendocrine recognizes the multiple hormone systems involved. Metabolic hits on the massive impact on insulin resistance, cardiovascular risks, and diabetes. And ovarian, of course, acknowledges the reproductive component. It's just a much more holistic, accurate view of the syndrome. To put the scale of this into perspective, we are talking about roughly 1 in 8 women of reproductive age worldwide. That is over 170 million people. It's easily one of the most prevalent endocrinopathies you're ever going to encounter in practice. And yet, crazily enough, it's still frequently underdiagnosed until a patient actually hits a wall trying to conceive. Moving on to Section 2, Endocrine and Metabolic Pathophysiology. Let's look at how this builds into a complex web of systemic cellular dysfunction. Let's break down this vicious cycle. We're talking about adipose androgen crosstalk. Visceral adiposity drives insulin resistance, right? Which then directly stimulates the ovarian theca cells to just pump out more androgens. That expanded adipose tissue enhances local androgen production, which then promotes even more visceral fat accumulation over subcutaneous fat. It's a relentless physiological feedback loop. And we can't forget the inflammation piece. This condition is intrinsically linked to low-grade chronic inflammation. Elevated pro-inflammatory cytokines like TNF-alpha and IL-6, they actively suppress hepatic SHBG synthesis. So when the liver makes less sex hormone-binding globulin, what happens? You get way more free, unbound testosterone circulating in the blood, which just reinforces that underlying hormonal imbalance and makes the hyperandrogenemia so much worse. Now, because of these profound endocrine disruptions, nearly 40% of women with PMOS develop full-blown metabolic syndrome. Let that sink in. 40%. This radically elevates a patient's risk for type 2 diabetes, atherosclerotic cardiovascular disease, and MASLD. It's a stark reminder for all of us that we are treating a lifelong metabolic threat here, not just a menstrual irregularity. All right, Section 3, Clinical Signs and Diagnosis. Now that we've got the pathology down, let's look at how this multi-system disorder actually presents in the clinic. So the classic diagnostic triad is still central: hyperandrogenism, ovulatory dysfunction, and morphological ovarian changes. But the 2023 International Evidence-Based Guidelines made a really smart update. They now incorporate elevated anti-Müllerian hormone, or AMH levels, as a true diagnostic marker for adults. This is a total game changer. It gives us a critical alternative when transvaginal ultrasounds are either non-diagnostic or just unreliable for our adult patients. Section 4, Limitations of Conventional Therapies. Even with a better understanding of the metabolic nature of PMOS, our old therapeutic toolkit has definitely fallen short. We see this all the time, right? Relying purely on lifestyle changes or metformin just doesn't cut it for the robust metabolic optimization we really need, especially for the 50 to 80% of our patients with comorbid obesity. We know the struggle. Lifestyle interventions are first line, absolutely, but sustaining that required 5 to 10% weight loss is incredibly hard due to biological adaptations like increased central appetite signaling. And then you have metformin. It's been the standard of care forever, but honestly, it generally yields only modest weight loss. Plus, those dose-dependent GI side effects, they constantly cause patients to just throw their hands up and abandon the treatment altogether. that brings us to Section 5, GLP-1 agonists and reproductive rescue. This is where things get really exciting as we look at how to actually break that insulin-androgen cycle. The multi-organ effects of GLP-1 receptor agonists are just incredible. Centrally, they act right on the hypothalamus to promote satiety and crush cravings. Peripherally, they're delaying gastric emptying. Over in the pancreas, they optimize glucose-dependent insulin secretion, which dramatically improves insulin sensitivity. And here's the magic. As insulin levels drop, the liver increases SHBG production, effectively lowering that free testosterone. Plus, emerging evidence is showing these agents exert direct anti-inflammatory effects on the ovaries themselves, essentially rescuing and restoring spontaneous ovulation. But it's not all smooth sailing. Despite their clear superiority over metformin and burning visceral fat, we face massive socioeconomic hurdles. Because PMOS is often considered an off-label indication for these meds, insurers routinely deny coverage until a patient develops full-blown type 2 diabetes. It's incredibly frustrating. It leaves so many patients facing exorbitant out-of-pocket costs and creates these huge inequities in access to what is genuinely advanced life-changing care. Finally, Section 6, Preconception Protocol and Key Takeaways. Let's translate all this science into an actionable, safe clinical workflow for patients trying to conceive. GLP-1 agonists are amazing for preconception metabolic prep, but, and this is a huge but, because of the unknown teratogenic effects of these long-acting agents during early pregnancy, a strict 2-month pre-pregnancy washout period is an absolute non-negotiable clinical necessity. You have to systematically step your patients down, transition them over to safe alternatives like metformin, combined with highly intensified lifestyle management to prevent that rebound weight gain before they ever initiate any ART cycles or unprotected intercourse. To wrap things up, here are your core takeaways. First, frame PMOS as a metabolic disorder to your patients, not a gynecological one. Second, prioritize comprehensive metabolic screening early. Don't let a normal ultrasound stop you. Check those lipids, check that fasting insulin. Third, aggressively target insulin resistance. Definitely consider GLP-1 RA and metformin combination therapy for obese phenotypes. And lastly, strictly adhere to those preconception washout protocols. I want to leave you with this question to chew on. As the medical community finally moves past the whole cysts misnomer into a true multi-system metabolic framework, how are you going to integrate GLP-1 RAs into your clinical PMOS and fertility optimization protocols? The science has evolved, the name has evolved, and now our practices have to do the exact same thing. Thanks for joining me on this explainer.